Good afternoon, everyone. This is a live case. We're here in room 1, an endoleak after EVAR. So our patient is a 75-year-old male with a history of AAA status post EVAR who presents with enlarging aneurysmal sac and endoleak. So his surgical history with regards to his stent graft placement, in 2000 he had an anurex stent graft placed. 14 years later, the stent graft had an aneurysmal neck dilation, slippage of the graft, and a type 1A endoleak, at which time he went and underwent an aorta uniiliac endurant 2 stent graft placement with a fem-fem bypass and had AVP embolization of his left common iliac artery. Next slide, please. He has multiple past medical comorbidities, diabetes, hypertension, CAD. From his other surgical history, more recently he had bilateral carotid endarterectomy. Next slide, please. His medications, he's on a couple blood pressure meds, aspirin, Zocor, and Xyloprim. This is a cine loop of the CTA that was done on May 2nd. As you guys can follow through here with these axial images, you can see a large endoleak, exclusion of the left iliac or left limb that was from the initial anurex stent graft placement. He had an AVP embolization of left common iliac, and he has a patent fem-fem bypass. The left hypo is patent and is filling retrograde, and the right hypo is still patent. These are some still images. This is the superior aspect of the stent graft. There's a curved replanar format of the renals at the superior aspect. Next slide. This is the distal right-sided limb. Next slide. An additional area distally in the aneurysmal sac. Next slide. So in summary, our patient has a history of AAA status post EVAR requiring revision and presents with endoleak. And we today have started with a diagnostic arteriogram from a transradial approach.
We have radial access with a 6 French slender sheath, and we put down a Jackie radial catheter. What I'm going to do is I'm going to show you now the diagnostic angiogram. At least just to start off the conversation, I think it's very obvious there's a type 1A endoleak. It's also very obvious to me there's a type 1B endoleak. And the stent graft going down the right side is very, very, very close to the internal iliac artery. Obviously, the fem-fem bypass graft is widely patent. I didn't specifically see a 3, but I'm not clear that it's going to change the way that we manage this case. Okay, and I'm curious if you would disagree with me about that, because I think we need to reline the whole thing.
Yeah.
And so I'm almost thinking that the type 3 is irrelevant to the interrogation. But from my perspective, I think he needs a completely new AU, all the way top, really suprarenal. Right up to the SMA, maybe even up to the celiac, and it needs to go down into the external iliac from this point of view. I think now is the time to sort of pause and plan a comprehensive reconstruction. My concern, my concern is largely based on the fact that I think we've all been sort of burned a couple of times, is that when you're dealing with very, very tight renal artery stenosis and you're planning on either doing a Z-fen or snorkels, sometimes things don't go as smoothly as if the renal arteries are widely patent. And so we've sometimes defaulted towards a preoperative revascularization just to make the procedure when you introduce either the Z-fen or the snorkels go much more easily.
Yeah, I mean, what I would generally tend to do is definitely for fenestrations, if there's a high-grade renal artery stenosis with a fenestrated graft, you can blow through contrast so fast, and it can be worse for the patient in the long run. So for those, if there is a high-grade stenosis, I would probably just angioplasty, just to open it up, and then order in a custom graft.
Okay. I think we're going to proceed with right internal iliac artery embolization. And if that angiogram is confirmed that I just showed you, bilateral renal artery angioplasty. Does that make sense?
Yeah, sounds good.
Okay. We had a lot of very, very heartfelt, serious conversations with our surgical colleagues. And there's a lot of things that we learned. And I'm going to ask everyone to look at a bunch of angiographic images here. Can we look at image number, run number 6, please? Can we show that, please? I'm going to stop for a second. So that's an interesting finding, and I think everybody who does aortic work will notice that the wire is being extruded between two components, and there was a little bit of a subtlety of whether or not we were seeing a type 3. Can we go to the next run, please? And next run, please. I think this is the AP. And once we sort it out, we're dealing with a 1A, a 1B, a type 3, and this renal disease. We honestly said that this patient really might best be served with an open repair and an explant. And I know that we're all sort of like endo first and everything, but honestly, with what we're talking about here, I'm not sure that we haven't reached the point of passing clinical equipoise. So I thought that it was a good idea to perhaps stop because this was just a little bit more complicated than I thought we were anticipating. Next slide, please. That looks like a tight lesion to me. I don't know about you guys. But what we thought we would do, and what we're right now in the process of doing, is actually determining what the gradient is across this. And we actually have our FFR machine set up and ready to go now. And I can show you guys, if you're interested in this setup, about how we do FFR for the renal, for transradial approach. If you can show in on my fingertips, we have a pressure transducer, which is transducing off the guide cath. And I'm not sure if we can show the Volcano screen here. It's the same as that up there. Thank you very much. But that's the red waveform. And then what we've done is we've introduced a second guide wire. I have a support guide wire in the renal artery. That's the first guide wire that we used to cross. I think there was a fluoro run of us crossing the renal lesion. And interestingly enough, even though this lesion looks so complex, the guide wire actually sailed right through. Interpret that how you will. And then we are actually trying right now to cross with a second wire, which is a pressure wire. And that's when I asked the cameras to go live right now. So right now you have a yellow waveform superimposed across the red waveform. And what we're trying to do live, basically, is advance the second wire, which you can see here probably on your screen, across the renal artery ostia. And now what you'll see is the platinum transition on the wire to stainless steel. As soon as that crosses into the kidney, you'll see what the gradient is across this renal artery lesion. And you see a real dampening. If we can go back to the translesional FFR gradient, you see a significant reduction in the waveform there. So, from my perspective, this is a real hemodynamic lesion. And I think no matter what we do with this patient, this is valuable information to plan. Clearly, if we plan to do an open repair, we're going to have to take this into consideration, whether we want to do an open renal bypass or whether we want to do preoperative renal stenting or some variation on that fact. But I always think it's a very good idea, no matter whether you're doing it in the setting of aneurysmal disease or non-aneurysmal disease, to measure a gradient before you do renal stent placement, and to make a decision about whether you in fact are going to revascularize the renal arteries based on a translesional gradient. I just thought I would share this with you guys about how we do translesional gradients here. like I said, I'm really trying to collect as much information as possible so we can make a really, really comprehensive decision about how we want to repair this patient's aneurysm. There's a lot of moving pieces here, as you can see, and I think I thought it was very helpful to show you guys how we make assessments of the renal artery. But I think it's very helpful for you guys to go to Aaron's room and learn how he closes. So I really appreciate your guys joining me on this very interesting case, and enjoy the rest of your day.